Hi, everyone. We are live at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. I am sitting here with Dr. George Adams from Raleigh, North Carolina, and he is an interventional cardiologist. He just got off the podium. He was speaking. He was actually also helping with a live case that was broadcast here. Looks like it was quite a challenging case.
Definitely challenging, but a great result.
Can you describe to the patients? I'm going to let you hold that for a
Sure.
second. I'm going to take it off blur so it doesn't keep blurring on us. Oh, much better. Perfect. Okay. Describe what it means to have a live case and what the doctors are doing. And you have a panel of different doctors, almost like, backseat drivers, in a case.
Yeah, absolutely. So first of all, the operators are technically gifted, so there's no question about it. But it's nice to have a consensus, especially when treating peripheral arterial disease. So the panel, more or less, is experts from around the world that are sitting there looking as the operator operates, and it's a banter back and forth in terms of how to personalize care to best optimize the outcome for the patient. It's great. It really is. I mean, it just takes into account all types of different devices, takes into account the patient, it takes into account what the experiences are, not only from the operator, but from the whole panel. So it's a great collaborative approach to treat the patient.
When coming out of this conference, I've heard a couple of things. Abbott did a presentation this morning about a new drug. I think it's a bioabsorbable stent.
It's a bioabsorbable scaffold. It's the Spirine, and recently, it's used for below the knee disease. We know that below the knee disease is one of the hardest areas to treat and to have good long-term outcomes. And so, what Abbott's come out with is this bioresorbable scaffold to hopefully keep the vessels open longer to improve outcomes, especially with people who have wounds or wrist pain.
Hopefully it'll change some of the doctors' minds who say that treating below the knee is not worth it.
Yeah, and I'd wholeheartedly disagree with that statement. To improve patient outcomes, to heal wounds, and to help people stay mobile, to keep them independent, you have to treat the entirety of the leg. Otherwise, the wounds just don't heal. The wrist pain doesn't get better.
Fantastic. Okay, I want to get to Marie and she can ask Dr. Adams the question. Okay, are you ready?
You want me to go first?
Yep, I'm going to go ahead and give him my earpiece so that he can hear you.
Right. All right, Marie, can you hear me?
Yeah.
Okay,
I
so what's your question?
I had a double bypass 3 months ago. So it was a fem bypass, and they
Yes,
put a
ma'am.
stent in my right iliac.
Yep.
And then they did angioplasty. And after when I woke up, I was in a tremendous amount of pain. And I kept telling them something's wrong, something's wrong. And from my knee down is like really, really bad. Like I feel like something is just choking me and my knee hurts. It took me 3 months just to be able to lift it.
Yeah.
And I just kept telling them something's wrong with my knee. Like it felt like it was broke. Um, well, and then I was having problems with my wounds and it had to be packed. And well, after everything cleared up and they did a test on me, they said my second bypass failed. I've been through 3 weeks of complete anxiousness. I just had another angiogram. I'm waiting for the test and I see my doctor this Friday. In between that, I called up my insurance company to see if I'm allowed for a second opinion. And basically, they said that if the second doctor wants to do what the original doctor wants to do, then I have to go back to the original doctor. So,
Interesting.
so and
Now,
I,
can
I
we
and
call
I
out
don't
that
know,
insurance?
and I don't know if what I have, and I don't know if I have nerve damage. I don't know what
Yeah.
this is. I'm breathing funny. The neurologist gave me gabapentin, but I just can't seem
Yeah,
to be
you have a lot
breathing
going
right on
on.
it. I'm going to bed at night. I'm sweating so
Yeah.
bad, and I don't
Okay.
know if I'm anxious. I don't know if it's my
Yeah.
circulation. I don't know what's going on. I feel like I'm worse. But
Yeah.
I mean, I was able to, I wasn't able to walk before. I was able to walk a little bit.
Yeah.
I had open wounds, but I was breathing. I'm walking a little better now, but not.
Okay. So let's let Dr. Adams jump in because we really understand, it is anxious, right? It's really stressful to go through that and be, have things fail and nothing seems to be going right for you, and then your insurance doesn't seem to support you. But maybe Dr. Adams could give you some really good questions to write down that you can ask your doctor to help ensure that you're getting the best care and you can maximize the time that you have with them.
Yeah. So real quick. So the question on the table now, is it an arterial problem, from the bypass going down, and is that the symptoms, where the symptoms are coming from? Number one. Number two is it a neurologic problem? Is it a function of poor arterial circulation that's affecting the nerve, or something structurally from the bypass? So that's the first two questions. And it can be a combination of both. It doesn't have to be one or the other. It could be both arterial and neurologic. So the first thing is to tease out what it is. So if it is arterial, then the question is there an opportunity to open up the native vessel? Because the bypass has already shown that it's failed. Okay, so that would be the next opportunity, I think. And there's some pretty unique things that we can do from an arterial circulation standpoint. Number one, you can use tools to open up the native vessel. There's also tools that you can actually pop into the vein, come down, cross the lesion, and then come back and pop right back into the artery. It's an endovascular type of bypass that we use a covered stent for. So there's some techniques and tricks that you could do, and that would give you options for the arterial circulation. Now, if it's something to do with the nerve, that's totally different. And there are medications to help with that. And a neurologist needs to advise us on that platform. But that's where I would start. The thing that's most important for you is to make sure that you keep that leg active. Okay. Don't become static. You got to keep moving. The saying, if you don't use it, you lose it. Man, it is true. So you got to keep your foot moving, your leg moving, even if you're just sitting in a chair. Every time a commercial comes on, which is every 15 minutes, do leg lifts, move your foot up and down. Okay. So, but the good thing is, it sounds like you're walking now. So try to continue to exercise, because what you're doing is you're building up those collaterals that actually feed more blood flow to the lower extremity.
Fantastic. Thank you, Marie. And if you want to reach out to me as well afterwards, we can help find you that second opinion through our Lifesaver hotline. Okay, Lucretia. Lucretia, go
Thank
ahead and
you.
unmute.
You're
Thank you,
welcome.
Marie. Lucretia, go ahead and unmute and keep the questions short if you can so we can get some more questions. And if Lucretia can't do it, why don't we get in Marcia? Marcia, go ahead and unmute.
Oh, hello? Can you hear me?
Yes.
Okay, hi. I had to pull over. Thank you for joining us, doctor. I
Absolutely.
wanted to ask you.
Well, you actually muted yourself.
There we
There you
go.
go. There you go.
Okay. Yeah. I wanted to ask you about claudication and diet. So
Yes.
I tend to walk a lot, and there are others in the group that do, but some days it seems like I can go, and other days it's like, whose body am I in? It's like I have to start all over. And I'm wondering if I eat something bad, like, how, I mean, I eat good usually, but, occasionally you have a hamburger or some pizza or something. How fast does that affect your ability to walk?
Yeah, it shouldn't affect it that acutely. Usually, when we talk about diet, it exacerbates your comorbidities such as high cholesterol, diabetes, blood pressure, etc. Now, I'll tell you though, is if your diet increases your sugars and you're a diabetic, that can act pretty acutely. So you want to make sure that you keep your sugars under control. So eating those fatty carbohydrate sugar substances you probably would not want to do that if you're a diabetic. That could affect it acutely, but otherwise, the high cholesterol, the high blood pressure, et cetera, usually happens over time.
And we did have a question that came in prior to the show. What are some of the medications that can help a patient improve their walking distance?
Sure. So in terms of improving your walking distance, so your typical medicines that affect cardiovascular health, right? So you're trying to decrease the amount of plaque that builds up over time. So you want to control your blood pressure. So ACE inhibitors, beta blockers, statins for cholesterol, aspirin, and Plavix are two antiplatelet agents that help. And there's been recent literature to show that antithrombotics also help. So Xarelto is the medication. If it's a neurologic issue that's affecting your walking, then gabapentin, Neurontin, those sorts of medications may help with walking.
Fantastic. Let's try Lucretia again. Lucretia, try and unmute. Go ahead and try and unmute. Or else we can get to, if anyone else has a question, or else I have one more question that I want to ask him so we can get him on his way. Lucretia, do you want to try there, or anyone else have a question?
I have a question.
Yes, go ahead, Douglas.
Yes, sir. Thank you for being here. It's about the learning. What do you see the biggest thing is in getting the doctors today to learn the new techniques so that when they see us, they can go below the knee and not just give up on us and go straight to amputation or something like that?
Yes, that's a great question. So education is huge. It's not just educating other physicians on these techniques and devices, but also educating them on people in their area that do these types of procedures. So if they can't do it, there's an option for the patient to go to someone who is skilled at doing it, because it's not like you can just read a book or do this once or twice. These are learned skills over time, right? So multiple patients that are done, you learn how to do it right, how to do it wrong, and you learn from your mistakes, you learn from your successes. So saying that, it's not just something, especially when you're dealing with below the knee disease, that you can just pick up. So I think it's more than just educating the physician that's doing it at your locale. It's also for that physician to understand who else is doing those procedures and is successful.
And my final question that came in, it's just along the lines of the amputation and doctors learning new things, right? What nowadays, with so many new technologies and techniques out there, what would be your threshold before you say, you know what, there really is nothing else that we can do? And, how does a patient know if there really is nothing else?
Yeah, so I'll be honest with you, there are so many new techniques, new devices. It's really from my standpoint unrealistic to throw the towel in anytime soon. The only time that I would say, listen, we've got to do something from an amputation standpoint sooner rather than later is if it jeopardizes the life of the patient. So if the wound gets infected, for example, okay, or the other place is if the patient says, you know what, I've had enough. Right. This is affecting my life adversely. And I just want to try to get this off. It's miserable and I want to try a prosthetic. But from a physician standpoint, if you have an opportunity to try to open up the native vessel, you've exhausted bypass options. Now we've got deep venous arterialization where we can pop in the vein and backfill the venous circulation through, backfill the arterial circulation through the veins. There's a whole host of techniques that we can use. But I think again, it's how far does the patient want to push it, number one, and then number two is what is the risk to the life of the patient systemically, not just the leg.
Perfect. I just want to check in with Lucretia and see. I feel terrible that we had her and she's having some trouble with her thing. Lucretia,
can you hear me?
There you
Yeah.
go. Yay! I'm so
can
glad
you hear
it's
me?
working.
Yes, ma'am.
Hi. I'm actually having a medical emergency today. I don't know if it's related to the pad. I woke up. I was a little off balance, probably maybe the last 2 days, but this morning I got up. I couldn't walk. My legs were numb and arms are burning. And I don't know why I'm so emotional with this happening today. And then I got a headache. And then I did throw up, but it wasn't food. I only threw up once. The headache went away.
The
I
hospital?
almost
Did
went
you
to the
go?
hospital. Huh?
Yeah, I'm thinking an emergency room stat.
Yeah. Yeah, I would just
Well,
go get evaluated in the emergency room or urgent care. They can draw some labs and see what's going on and
well,
get an
I almost went to
EKG.
the hospital, but I called my family doctor and I got an appointment with her at 3 o'clock. But I almost
Perfect.
was scared I was having a mini stroke or something. It was bad. My head still, I feel better. My head still don't feel right.
Yeah, and you bring up a great comment. You know, when people have peripheral arterial disease, PAD, as you say, you're also at risk of getting blockages in other vascular systems, your heart and the vessels that supply your brain, right? Because all your plumbing's connected. Your body's the house and all your plumbing's connected. You get a blockage in one part of your plumbing, you're at risk of getting blockages in other parts of your plumbing. So I think it's intuitive that you get checked out by your family physician. And if it gets worse, call 911 and get an emergency room physician to see you.
Any critical
Well,
questions she can ask her doctor?
I
Well,
have
well,
I
yep,
have an
go ahead.
angio scheduled for June 12th.
Okay.
And because something's
But
going on again with my right leg, but this happened today. I don't know where to turn to, which doctor to go to.
y- yeah, I would go to a
I don't
general
know if it was
doctor.
from my pad.
Yeah, I would go to your general doctor first or the hospital just so you can be checked out systemically. And then we can follow up your peripheral arterial disease in June whenever you have that procedure.
Okay, thank you.
You're welcome.
Thank you, everyone. Thank you so much
It's
for
my
your
pleasure.
time. I really appreciate it, especially I know everything was delayed, so I just want to make sure that you get to where you need to be, and we'll of course have you back again. So everyone, just we're gonna hang up now. We have doctors throughout the day, so if you didn't get your questions in, go ahead and tune in a couple of hours, and we will have more with a couple.